and a delight and pleasure to invite my colleague and friend, Mr. Nicos Kessaris, who is a pediatric and adult transplant surgeon and who's a huge resource for us across in London. He has come to give us an overview on dialysis and transplantation issues in ARPKD. Thank you, Nicos, for your time.
Can I just add to that, Manish? Nicos has been here since we started, and we've not heard from him yet, but I think what that's illustrating is why he's a surgeon. He's clearly got great patience. But no, thank you and welcome. Over to you.
Thank you very much, both for the invitation and the kind introduction. I'm going to share my screen. Hopefully it will work.
Nicos, you're on mute, sorry.
Sorry, yeah. Somebody had to do it today. Anyway, thank you again for the kind introduction. I'm going to talk a bit about dialysis and transplantation. I work at Guy's on the adult side, but also at Evelina and Great Ormond Street for the pediatric side, but also occasionally go down to King's and do a kidney transplant in a pediatric patient. But haven't done one for ARPKD yet. As we've heard, it's not a common thing, but we've just done one for methylmalonic acidemia a couple of months ago. This is just an overview of what the situation is once a child, any kind of child, needs renal replacement therapy. So the majority of patients do have peritoneal dialysis, and you can see with respect to transplantation, it's about a quarter, and the rest are on hemodialysis. As we've heard before, it's with respect to peritoneal dialysis, it has extra advantages in the smaller kids in that it makes the abdomen a bit bigger so that they can then have an adult kidney transplant that takes usually half the space in the abdomen. And indeed, I think there was a question earlier on, at what point do we actually do the kidney transplant? So we tend to try and grow the child to about 10 kilograms. And as I said before, it's for the kidney to fit in. And I'll touch upon that point a little bit later on as well. So talk a bit about peritoneal dialysis first. So we need to assess the child, of course, and make sure there's a favorable abdomen, not a lot of previous surgery. And indeed for polycystic, well, ARPKD, there may be some hernias, for example, especially an umbilical hernia. And we see that occasionally that we need to take into account when we put the PD in and that we need to repair it. But as also said earlier on, it doesn't matter if there's big kidneys in, you can still put a PD catheter in and dialyze. And that's how a PD catheter looks like. Of course, if any child needs it, they'll have all the training and they'll become familiar with, the family will become familiar with all this and how it looks. But essentially, if I can point here, this sort of squiggly bit has to be in the pelvis. There's a couple of cuffs here. Some catheters just have one. That needs to be in the sort of abdominal wall to adhere the catheter so it doesn't come out. And usually it's this part that is outside the body. And this is just an perioperative procedure picture. So this is the pelvis, that's where the catheter will end up. And the cuffs will be in the abdominal wall, as I said previously. So that's a picture of a PD catheter just put in, and the catheter part that is exposed outside. Now, these pictures come from InfoKit, which is a UK-based website that has a lot of information, both on dialysis as well as for transplantation. And these pictures are from there. So some children will have lines put in the main veins in the neck and dialyze through that. The downside of that is it can cause thrombosis of some of these veins that cannot be recovered essentially and cause more problems down the line as the children grow up. And those are put usually in the interventional radiology department, of each hospital. With respect to fistulas, we are both Evelina, Greta, Mr are centers that do fistulas in children. Some hospitals, some pediatric hospitals don't do them at all. We occasionally get referrals from outside, and yeah, you do need a good vein and a good artery to create a fistula. So you need to assess the child's arm, and we always do scanning to assess these vessels and measure the size, because ideally we need a vein of about 2 millimeters. And the arteries, of course, in the children, when compared to the adults, are much smaller. So the inflow needs to be assessed or predicted before the actual procedure. So most of the children that we do fistulas on are more than 2 years old. We've done a couple in about 18-month old children. But as I said before, most of the children probably have, as I said, PD and some with the lines. Just to give you a little bit more idea about fistulas. So for example, here you can see, this is one of the arms, left arm, around the elbow joint, and we've got one artery and one vein in parallel. And essentially what we do is a cut and diverting the vein onto the artery, just like shown here, so that part of the blood, instead of going all the way down to the hand, is diverted up the vein to make that vein get bigger to allow us to dialyze after about 6 to 8 weeks. And this is how it looks in a patient. This is only a few weeks old, so it's not very prominent in the vein, but it's adequately maturing fistula. And of course, there's different types of fistulas. It is higher up in the arm of a different patient that needs, the vein is actually quite deep and needs mobilization, and hence the bigger incision. So there's a number of different options there with respect to fistulas. Now, with respect to transplantation, of course, it will free somebody from dialysis, give them a better quality of life as well as their family, and they will live longer. So the benefits are obviously very good. And of course, we've got deceased donor kidney transplantation and live donor kidney transplantation. Having a live donor obviously comes with advantages, and glad to say we do more living donors than deceased donors. And in the UK, we do about 130, 135 in a year. That was, of course, pre-COVID. In the last year, we did only 100 because we have to stop mainly the live donor programs to protect mainly the donors, but also the children as well in the first wave. But we're completely operational now, and we're picking up in numbers. Of course, having a live donor where the kidney will not have to travel far, the donor will not die, you know, and it'll be a much better quality kidney. The outcomes are better. Every child will have a number of tests and go through multidisciplinary team members, including you know, psychosocial, and if eventually they come to see us, usually multiple times, just to make sure the whole thing is done properly, and we teach essentially their families of what to expect with respect to transplantation, and have them on board as well as a child. And then we either proceed to the live donor transplant or to listing the child on the waiting list. Now, in the UK, the national body is NHSBT, NHS Blood and Transplant, that allocates the kidneys essentially. And this the center is in Bristol. And essentially, the allocation system has to do with you know, matching the blood groups, or compatible blood groups. They favor the best match, so that there's less long-term risk of antibody development if the mismatch is not good. Obviously, waiting time is important. So if you're on the list today, you won't get a kidney tomorrow, but if you've been waiting for a year in the pediatric side, you will start maybe getting some offers. And most of them are transplanted within well, I would say now probably 12 months to 14 months. The slight delay, it used to be 1 year, but since the allocation system changed a bit, as Tassos mentioned in 2019, there's slightly more waiting, but apparently that should improve with time. Obviously, we don't want a big age discrepancy, especially if the recipient is a child. And by sensitization, I mean with respect to antibodies in the blood of the recipient that might reject the kidney. So if it's if there are a lot of antibodies, then those patients get more points and more likely to have transplant. So on the deceased donor list, you know, your loved one will get a phone. Well, the family will get a phone call for the loved one to come in to have a transplant. We'll ask them to stop eating and drinking, come in, have a lot of tests, including the COVID tests now, and of course we check the donor as well, and then proceed to transplantation. And that's how we do the operation. Essentially, we have two approaches in children. One is when the child is over a certain weight, so more than 20 kilograms in our centers, we'll put the kidney onto the vessels here. So those are the common iliac vessels or external iliac vessels, as opposed to the main vessel in the middle of the tummy, the inferior vena cava and the aorta. And it will zoom in with the ureter as well to do, and we join that to the bladder, as you can see here, over a little plastic tube called the stent, and that's how it looks. And that's to reduce the risk of a narrowing at this point or a urine leak to develop that might need further surgery, but luckily it's not a common thing. Now, if the child is much younger, and this varies from unit to unit, we do what's shown in figure A. So we put the main vessels onto the higher up into the abdomen, onto the aorta, and inferior vena cava, because as you can imagine, the space is much less. And talking about space, when there's a mismatch, what we've done during living donation, we've 3D printed the donor kidney, you can see here, and the recipient's abdomen, and try to match the two beforehand. And this particular case was videoed by Sky News. But you can see in this picture how big the kidney is and how small the abdomen is, and trying to fit the two in can be tricky sometimes. When we compare our results with less than 20 kilogram recipients and more than 20 kilogram recipients, the outcomes of the kidney grafts function was the same, was similar. After each transplant, we do a scan of the kidney to make sure perfusion is, or the blood supply to the kidney is as good as it can get. During the procedure, they'll get, the child will have a central line, urinary catheter, a wound drain. Also put a little catheter in the wound with local anesthetic going in for the first 48 hours, try and have as much pain relief as possible. And the children tend to stay in hospital a bit longer than the adults, so maybe between 7 and 10 days. And this then comes out 4 to 6 weeks later. And of course, we keep an eye on them in clinic with respect to kidney function and immunosuppression levels. So from the surgical complications, we may have bleeding and may need a blood transfusion, but it's not common. Infection is probably more common. It can be any kind of infection, also viral, bacterial, fungal. Very small risk of clots. There may be a history of clots that we may need to adjust how we do the procedure at the time. And there is a very small risk of a clot in the kidney, losing the kidney early on. Risk of reoperations, we talked about ureteric potential risks. It's rare for kidneys not to work, especially in children, because of the fact that they're usually age-matched and they're younger donors. Rejection, yeah, it can happen maybe about 15% of the time, but usually we can treat that. And there's immunosuppression risks, including infection. and small risk of diabetes or cancer. So we keep a good eye on them in clinic. With respect to live transplantation, you have a few more options. You can do incompatible transplantation, blood group, or tissue incompatible transplants. And we've got national schemes, so-called kidney sharing scheme or pair donation scheme, that runs 4 times a year to try and match incompatible pairs with a compatible kidney. And of course, you can have non-directed altruistic donors as well that can contribute to the live donor scheme. Very briefly, so we'll try to match the blood groups, but if they're not, then we've got a problem because the kidney will reject because of antibodies. But we have ways of going around that. I'm not going to go into detail, but we can give extra medication, what we call here rituximab, or in addition, remove some antibody from the blood to make it possible. I don't have a picture of a child. I've got a picture of this gentleman that I transplanted back in 2009. I just want to show you the machine next to it, and that's what does the removal of the antibody. This little column here on the left that can cost £2,000 or £3,000 to just have one session, and he doesn't mind having his picture in because he's already in the newspapers. He's actually a journalist and doing well since then. Now, there might be some extra risk, including rejection, infection, of cancer, but actually infection rates, we found that they're similar. Cancer is a rare thing, and we haven't even seen much in the adult population. We've done more. And with respect to rejection, I'll just show you the first 11 cases we did here. Don't worry about the details. It's just to show that rejection rate, when you compare those 11 with another 50 compatible transplants, it was similar. Also, you can do, as I said, tissue incompatible transplants, but I'm not going to go into a lot of detail. These are a bit more difficult, and the outcomes are similar to deceased donation kidney transplantation. And this is a pair exchange that I mentioned before. So the picture here, we have a donor who cannot give to the recipient, to their own recipient. So they give to another recipient, and then we just exchange the kidneys. And then you can have different pairs where you can achieve that to have a compatible transplant. Now, we've already seen Max present this beautiful paper. The red lines, it was about 41 patients here, 41 lines. The red is kidney impairment. Blue is when they have a kidney transplant. It's about 12 or 13. You can see in this group where there was longitudinal data. The purple is a combined kidney liver, and you can see it's much less. That's about, I think, 4, and this is the age group between sort of 0 and 20 years of life. So we're just concentrating on that, and you can see there were none combined kidney liver. Sorry, there were none just liver transplants. There's only 2 in this population after the age of 20. And I also showed this paper of some 200 patients with ARPKD, young patients, and only 32 out of those had gone combined liver kidney transplant. This is an international study, so patients from all over the world. The majority had undergone kidney transplantation. And as we heard before, the kidney transplants, the results at 5 years were excellent, and with respect to kidney liver, the outcomes were 87% survival. So we talked a bit. I've rushed it a bit just for the benefit of time, but we talked a little bit about dialysis and a bit about transplantation, and I'm happy to take questions. Thank you.
Thank you, Nicos. That's really helpful and a very good overview. I think we are into the question time anyway. So what I might do is I'll sort of read out some of the questions from what your talk has generated, and then we'll start going through the questions which generally to the panel. So just one which you touched upon, why is kidney transplant ages, why does the recipient have to be at least 2, possibly around 2 and 12 kilos. I think you talked a little bit about size. I don't know if you want to just expand on that, perhaps.
So with respect to size, a kidney is usually 10, 11, and sometimes even bigger centimeters in length, and therefore when you measure the abdomen of a child of about 2 years old, let's say 10-kilogram child, it'll be about 20 centimeters, between 15 and 20 centimeters in length from the ribs to the pubic bone. So trying to implant a large organ, and of course for liver you can split it and make it smaller, but for kidneys it's not been done yet. So unless it's a pediatric donor where you can do that, and of course the smaller the donor, you end up putting both kidneys in, so it causes slightly different problems to take into consideration. So size is important. Occasionally, maybe once a year, once every 2 years, we might need to put a mesh to close the abdomen, and that's okay. And when we do liver kidneys, we occasionally have to use a mesh or even a deceased donor abdominal wall to close. So yeah. Just wanted to mention, maybe to catch up on one of the questions before, I found a paper about whether we remove ARPKD kidneys beforehand, and it was from Michigan. They had 11 cases, and these were all symptomatic young children essentially, and fortunately 2 died within a couple of weeks of diagnosis. So the other 9, essentially they all had bilateral nephrectomies in there, and half of them had the one, and then eventually they needed both within a month. So if you're symptomatic, you're more likely to lose your kidneys, it seems. But as Max said, if we can avoid it, it will be better. Thanks.
And just related questions. So are live donors always known to the recipient, or do you get healthy people donating to an unknown person? So I think you touched upon shared schemes, donor schemes as well. I think, and there is also the altruistic donation. Perhaps you want to just briefly talk about that.
Yeah, I mean, in the UK, we have maybe about 100 altruistic donors per year, which contribute obviously not just to have a direct transplant, but sometimes in chains, and therefore accomplish more transplants. And indeed, we've had maybe more on the pediatric side, the occasional Facebook in a way advert to try and get donors. And indeed, we had a case at GOS where we had more than 20 potential donors come forward, and obviously didn't know the child, and eventually we went with one particular one, but they can overwhelm the systems as well, because you can't screen 20 donors or 30 donors. But yeah, I mean, they're amazing people, all donors, in fact, and they contribute a lot, including for pediatric transplantation.
Yeah. And there's a question, Nicos, just last one to you specifically. What do you look for when finding a suitable matching kidney? Perhaps you might be able to guide towards a website or information site. Maybe you could type that out later, do you think?
Yeah, well, we use a lot the InfoKid in the UK, and indeed nationally we don't have a lot of different leaflets. We point everybody to that. So I'll find the website and put it in.
Thank you.